This is chapter 3 from Bontrager's textbook of radiographic positioning and anatomy. This is the beginning of lecture on abdomen. So this starts on page 106. When they start off looking at abdomen or talking about abdomen, you can see that there are in parentheses the initials KUB, and that stands for kidneys, ureters, and bladder, because typically on an AP abdomen you have to make sure that you include both kidneys, the ureters, and the bladder, all the way down to the pubic symphysis on that. When they start talking about abdominal radiography, they talk about the most common image is an AP supine abdomen, which can also be referred to as a KUB because of the regions that actually are visualized. And a lot of times they'll take this image prior to giving contrast media to a patient so that they can visualize what the abdomen looks like before contrast media is administered. And when it's done like that, it's considered a scout image. Scout, S-C-O-U-T. And that scout image is basically proof or something for the radiologist to refer back to show what the abdomen looked like or what was contained in that abdomen before they actually gave the patient the contrast media to show the anatomy or the hollow organs or whatever it is that they were actually visualizing. So that's called a scout image, and that is simply an AP supine abdomen taken prior to contrast media ingestion. On a well-visualized abdomen of a stenic patient, typically you will be able to demonstrate what are called the psoas major muscles. Psoas is spelled P-S-O-A-S, but notice that the P is silent. So the three major muscles in the abdomen that are associated with the abdomen, you have the diaphragm, which is an umbrella-shaped or dome-shaped muscle that separates the thoracic from the abdominal pelvic cavity. And then we have the right and left psoas major muscles, and those are located on either side of the lumbar spine. So typically, the lateral borders of those muscles are visible on a diagnostic abdomen on a average or normal-sized patient if the exposure factors are correct. Okay, so right and left psoas major and the diaphragm are the three muscles that are contained in the abdomen. When we look at the muscles and the soft tissue landmarks, again, this demonstrates in this radiograph, you can see these arrows are actually pointing to the psoas major muscles. And if we were to outline those, you can kind of see it coming down just like this on this side, and just like this on this side. So that's the lateral border, this border right here on either one. Okay, so proper exposure factors on that particular image. You can see all the soft tissue in there. You can see that they've included the pubic symphysis on there. They do have a marker, and then you can see the outline of the right and left psoas major muscles. As far as the digestive tract, a lot of the organs that are contained in the digestive tract and the accessory organs are actually found in the abdomen. So when they start with the digestive system, they reference that there are mainly 6 organs that make up the digestive system. You have the oral cavity, which is in the mouth, the pharynx, which can hold both food and air, because remember the pharynx has 3 parts. You have a nasopharynx, oropharynx, and laryngopharynx. That leads us to the esophagus, which carries the food from the oral cavity down to the stomach, which is our 4th region. And then we have the small intestine, which is made up of 3 parts. You have the large intestine, which is multiple parts. And then it also demonstrates the accessory organs of the digestive system, which include your liver, which occupies most of the right upper quadrant, the gallbladder, which sits underneath, kind of nestled under the liver, and the pancreas. Okay, and the pancreas sits in the C loop of the duodenum, and secretes enzymes for digestion. All right, and then the spleen is not considered an accessory organ. The spleen is actually part of the lymphatic system. They do demonstrate it just to show you for reference where it actually sits. You can kind of make it out right over here, but the spleen is actually part of the lymphatic system. When we look at the breakdown of the stomach and the small intestine, there are actually multiple parts to the stomach, even though it's just labeled as such. But you have the esophagogastric junction, which is where the esophagus comes and dumps into the esophagus. So you have an esophagogastric junction. Then you have the fundus of the stomach, which is the part that sits the most superior and posterior. So you have the fundus. Then you have the body, which is the middle portion of the stomach. And then you have the pylorus, which is the final section. And the pylorus actually leads into the duodenum, which is the first section of the small intestine. Okay, so the duodenum is the shortest section, and it's also the widest. The duodenum is roughly 10 inches in length. And the duodenum has a C shape to it, and in the C-shaped duodenum, that is where the head of the pancreas sits, and that forms what's called the romance of the abdomen. So the duodenum is the shortest section. It's also the widest section, approximately 10 inches, which is very short in comparison to the 18 feet of small intestine that make up the structure in a human. Next, you have the jejunum, which makes up 2/5 of the small intestine. And the jejunum is unique in that it has little villi in there, which are little microvilli or like hair-like projections that give it a feathery appearance, or it kind of looks like pillow stuffing on a radiograph. Okay, and then the last portion of the small intestine is the ileum. Now notice the spelling is different from the ileum, which is the bone also found in the pelvis. The bone in the pelvis, or the wings of the pelvis, are ilium, which are I-L-I-U-M. And this ileum in the small intestine, the terminal portion, is called, or is spelled I-L-E-U-M. And that makes up the 3/5 of the small intestine. So the longest section is the ileum, followed by the jejunum, and the very shortest segment of only 10 inches is the duodenum. When we look at a radiograph of the small intestine, notice you can see now this stomach has barium or some kind of contrast media in there. That's why all of this shows up white, because normally in an abdomen without contrast media, this is what it would look like. You would just have all of those things are still contained in the abdomen, but you're not able to visualize them without contrast media. So when the patient ingests contrast, then you're able to fill these hollow organs with the contrast media, and you're able to see the stomach. You can see the rugae in the stomach, which are the mucosal folds that allow for expansion. Okay, so you've got the fundus pretty much full of barium here, the body and the pylorus. Duodenal bulb is right here. Then you've got the letter that's referenced by A here is the duodenum. And then you've got the jejunum over here, which notice how it looks kind of feathery, or almost like when you sponge paint something. It has that appearance, and that's because of the villi that are found in the jejunum. And then the biggest section of the small intestine is actually referenced in the region of letter C, which is the ileum, spelled I-L-E-U-M. And they're showing here, this is the region where the terminal portion of the small intestine, the ileum, dumps into the first portion of the large intestine, which is the cecum. So this is called the ileocecal valve. Right? When we go into looking at the large intestine, now that tends to form the periphery of the abdomen, or it spreads to the furthest region from side to side of the abdomen. All right. And when we look at this picture, the large intestine, you've got the ileocecal valve. So when it comes through the terminal portion of the small intestine, it would dump in through the ileocecal valve. Then we have the cecum, which is the blind portion of the large intestine. And off the cecum, if the patient still has it, is your vermiform appendix. Vermiform referring to worm-like as far as its shape. So you have the vermiform appendix that comes off the cecum, assuming the patient still has it. So you've got the cecum, and then you've got the ascending colon. Then at the top of the ascending colon, before we get into the transverse, we have the right hepatic flexure. So it comes around, leading to the transverse colon. Then we have the left splenic flexure, the descending colon. Then you have the sigmoid colon, which typically has a significant S shape to it. Then you have the rectum, and then finally it goes out through the anus. Now that would be the path that food would follow, starting with the ileocecal valve and coming around. If we were doing a barium enema, it actually goes backwards or retrograde. So the enema tip would go in the rectum, in through the anus, in the rectum, and then the barium would flow backwards all the way till the ileocecal valve. Okay, and then it also shows you the liver, which is one of the accessory organs. The gallbladder would be nestled underneath here. The pancreas would sit somewhere up in this region as well. Okay, so you've got the gallbladder, the liver, and the pancreas. And then the spleen, we said, is part of the lymphatic system. All right, and then they show you the accessory organs of digestion. And the reason, I'm not entirely sure why they keep showing the spleen, but if you look on page 108, they do say that there are 3 accessory organs of digestion. That is the pancreas, the liver, and the gallbladder. And accessory organs are basically outside of the digestive tract, but they aid in digestion through materials that they secrete into the digestive tract. So the spleen, again, is part of the lymphatic system, which is part of the circulatory system as well. And it says that it is an important abdominal organ that occupies a space posterior to the left side of the stomach and left upper quadrant. Okay, but sometimes it's actually visualized on an abdominal radiograph. So the spleen is not an accessory organ of digestion. It is part of the lymphatic system. So the only 3 are the liver, the gallbladder, and the pancreas. And when I was saying that the head of the pancreas sits in the C loop, that's what I'm talking about right there. So where that sits, let's draw it in black here. The C loop of the duodenum would come around like this, and when it nestles that head of the pancreas like that, this is referred to as the romance of the abdomen, kind of like where the duodenum is actually hugging the head of the pancreas. Now, in this chapter, notice they also reference some CT images. This one is on page 108. And the only thing they want you to start being able to appreciate is when we look at CT, they are sectional images, meaning the body is sliced, almost like a loaf of bread, and you pull out each slice. So you want to just start familiarizing yourself with how the organs look in sectional images. So you can see this big portion over here, and they've labeled for you the right, the left, the anterior, and the posterior. So if this was a patient lying on the table, you would basically be down by their feet looking up. So their head would be up here, feet here, right side, left side. Okay. Now you can see the liver over here that occupies most of the right upper quadrant. You can see these little white dashes around the outside are actually ribs. You can see that you've got the spine back here, and they're labeling it for you as thoracic level T10 or T11. They're showing you the aorta. The stomach is full of contrast media or barium sulfate in here, and some of the large intestine they're referencing. So this is about teeth in T11, and then they also show you an image that goes down towards the lumbar spine, approximately level L2. So you can still make out that the liver is here, but notice now you can start to see like the kidneys coming into play. You can see the inferior vena cava, the gallbladder is visualized. Now, would I expect you to pull all of these out? No, but the first things you typically want to look for is, are you still visualizing ribs? Can you make out where the liver is? Are you in the bulk of the liver, like, you know, where it's still taking up a good chunk of the whole right side, which means you're not through the whole liver yet. Kind of when you get to the lumbar spine, you can tell that you've come down through the bottom of it. Now you're on the underside of it. That's why you can visualize the gallbladder. So just something to start looking at, making note of the anatomy, looking at how it's visualized and how it plays out is a good thing to do. They also reference in the abdomen, they show you the urinary system. And the urinary system is typically composed of kidneys, ureters, and a bladder. Typically, a patient has 2 kidneys, 2 ureters, and 1 bladder. And the reason that kidneys are visualized on an abdominal radiograph is because they typically, you can make out the suprarenal or the adrenal glands that sit on top. So it makes those visible. Now, when I say they typically have 2, it is possible to have 3 kidneys. Some can have 4 kidneys, or what they call double collecting systems. You can have 2, 3, 4 ureters, but typically a patient only has 1 bladder. And you need 1 kidney minimally in order to survive. If you don't have a kidney or the kidneys are not working, the patient would have to be on dialysis to filter the blood. Otherwise, the patient would not survive. If they did not have any working kidneys and they were not on dialysis, they would not survive for very long. When we look at an intravenous urogram, an IVU, that is also found on page 109, and they're just pointing out to you that you can see the kidneys collecting the contrast media. With picture E, this is showing you where the suprarenal gland is. A is referencing that this is the left kidney, and this would be in the area of the renal pelvis. And then you can see both ureters coming down from each of the kidneys, dumping into the bladder. So that is a really good image from an venous urogram, which is an abdominal study where they give the patient an injection of contrast media. It filters through the bloodstream. The kidneys actually pull it out because it is mainly composed of iodine or waste product. The kidneys collect it, filter it out, and then excrete it from the kidneys down to the bladder via peristalsis. When we look at some of the other anatomic relationships in the abdomen, you can see that this is a mid-sagittal section. So they're actually looking from side to side on the patient. And you can make out, you can see this is the anterior portion of the patient, posterior portion, you can see the spine coming down. You can see all the visceral peritoneum that lines to the organ. The parietal peritoneum lines the wall of the peritoneal cavity. And then they've got greater and lesser omentum and mesentery in there, which we'll look at in just a minute. So this would be like a side image if you were to slice the patient in half from side to side and actually look at the anatomic relationship in there. Now, when they show you the omentum and the mesentery in there, the omentum, they show you that you have greater omentum, and on the last picture we saw lesser omentum. And the greater omentum is basically like a fat drape or a fat sheet. Okay, it's a double fold of peritoneum that extends from the stomach to other organs. And the lesser omentum extends superiorly from the lesser curvature of the stomach to the liver, and the greater connects the transverse colon to the greater curvature of the stomach from beneath. So it's like a big fat drape. And the purpose of that is so that the organs don't just bounce around. I mean, if you think about it, when we run, when we walk, if we were to hop up and down or we jump, it's pretty interesting that the organs don't jumble around with us. They kind of stay in place. And part of that is because of the greater and the lesser momentum that basically holds everything in place. We can also look at that sagittal section again. When we look, you can see that they've got the, you can see the lesser omentum outlined here. They're showing you like where the stomach is, the transverse colon, the mesentery. The mesentery, basically underneath the mesentery, it tells you that the peritoneum is large folds that actually bind the abdominal organs to each other and to the walls of the abdomen. And the blood and the lymph vessels that supply those organs are contained in those folds of peritoneum. Okay? And the double fold that holds the small intestine in place is your mesentery. So it's a double fold of peritoneum that actually holds the small intestine in place. And the omentum pretty much goes from the stomach to other organs. So both of those are basically like double folds of peritoneum that actually help hold everything in place so that it doesn't just jumble all over the place. When we look at some of the organs that lie retroperitoneal and infraperitoneal, this is actually a chart on page 111. Table 3.1 shows you that there are specific organs that lie within the peritoneal cavity, and those are your liver, your gallbladder, your spleen, the stomach, the jejunum, the ileum, and the cecum, transverse and sigmoid colon. Then you have certain organs that lie retroperitoneal or behind the peritoneum, like your kidneys, ureters, the adrenal glands, the pancreas, the C loop of the duodenum, the ascending and descending colon, the portion of the upper rectum, and major abdominal blood vessels like your aorta and inferior vena cava. And then you have things that lie infraperitoneal, and the things that are infraperitoneal mean that they lie below the peritoneum. Things like that would be your lower rectum, the bladder, the reproductive organs lie infra or below the peritoneum. Just an interesting concept, because when you think about, do they lie within the peritoneum, behind it, or below it? Quite a lot of organs in that actual abdomen that have to go somewhere, which accounts for body habitus that we've talked about before, like the framework of the body where everything fits into place. Like we said, small intestine typically goes in the center of the abdomen. Large intestine tends to line the periphery or the wall of the abdomen. Then they go into talking about the quadrants and the regions of the abdomen. And the regions of the abdomen we don't really look at, but it is possible. A lot of anatomists will actually use the regions, but for our purposes, when we're imaging a patient, we tend to break the patient into 4 quadrants. We have right upper quadrant, right lower quadrant, left upper, and left lower quadrant. And notice when you're looking at the patient, you have to realize that this is done as if the patient is looking at you, okay? So they're facing you, and you've got right upper, right lower, left upper, left lower. So it's opposite yours. And then when they divide that out, they're showing you how the liver occupies most of the right upper quadrant. You can see the stomach occupies most of the left upper quadrant. And then you've got various other organs that lie in the other. Now, why do we do this? We typically reference the quadrants because when patients are pointing out where either pain or where their discomfort is or what's going on with them, a lot of times they will use their fingers and point to reference. And it's hard to pinpoint exactly where they're pointing, but if we divide their body into quadrants, it's easy for us to say patient complains of pain in the right lower quadrant or wherever the case may be. So quadrants are definitely something that we use quite often. As far as the topographic landmarks, they point these out in an anterior position and a lateral. So these are things that we palpate, meaning that they correlate to other anatomy, and we use our hand and gentle pressure to palpate where these items are. So number one on both of these references the xiphoid process, which lies at T9, T10. And that is used a lot of times to show midline or to reference where the midline of the patient is. Number two references the inferior costal rib margin, which aligns to the level of L2, L3. We use that a lot of times when we position for upper GI. We go by the lower border of the ribs right there. Number three references the iliac crest, which correlates to the level of L4, L5. When people say they have their hands on their hips, truly they have their hands on their iliac crest, okay, which is the very top portion of the ilium. Number four, when they reference, is the ASIS, or your anterior superior iliac spine. That is the small protuberance that juts out on a patient when they lie supine or on their back. They can they can palpate those two bumps that come up in the front. Those are your ASIS, or your anterior superior iliac spine. Number five references the greater trochanter. And the greater trochanter, actually on this AP image, they don't point it out as well, but number five would be right here where that little protrusion is. And that correlates to the pubic symphysis. So a lot of times we use that as a reference point. Instead of palpating the patient's pubic symphysis, we simply palpate the greater trochanter, and it's actually found on the femur. Number six is the pubic symphysis, which is the lower border of the abdomen. It references the lowest border of the abdomen, or the inferior border, and that is your pubic bone, the superior portion of the pubic bone. And then number seven is the ischial tuberosity, which is on the ischium. It's the lowest portion on the ischium. Like if you were to sit on bleachers and watch a baseball game, and then the next day your rear end is kind of sore because your backside was digging into the bleachers, the thing that are actually sore are your ischial tuberosities, and they reference that you could use that as a landmark as well. So all of these 1 through 7 are topographic landmarks that we use to kind of help us identify where in the body we actually are. It correlates with specific anatomy. We also have some topographic landmarks on the pelvis. So you can see you've got the biggest bones in the pelvis here are your ilium, spelled I-L-I-U-M. Those make up the wings of your pelvis. Then you have the pubic bone, and where that joins in the center is your symphysis pubis, or your pubic symphysis. And then you've got your ischium, which are on the bottom. Okay? And that is referencing your ischial tuberosities. Your ASIS is on the front, the iliac crest at the top, and then the front portion, the anterior portion, is your ASIS. And those are found on page 113. As far as positioning, radiographic positioning of the abdomen, there are several positions. We'll only talk in this lecture about the AP supine abdomen, but there also is, in addition to that, we have an erect abdomen or an up abdomen. We have decubitus abdomens, dorsal decubitus, lateral decubitus. We have lateral abdomens that we can do. And then these are just some of, like an acute abdomen series we'll talk about. The decubitus we'll talk about in another lecture. And remember, the KUB is equivalent to an AP supine abdomen. When we talk about the patient prep for an abdomen study, recognize that the patient has to then remove all of their clothing and any radiopaque objects in the area that's going to be imaged. So the abdomen typically starts at the diaphragm, is the superior border. And the inferior border is the pubic bone. So anything that covers the body from the diaphragm to the pubic bone ideally should be removed. So that would include usually shirts, bras, shorts, jeans, anything that is going to have any kind of radiopaque objects. So anything with metal, snaps, buttons, zippers would have to be removed, and that includes underwear. If the patient has any radiopaque objects on their underwear, they would need to remove them. And they would put a gown on, typically open in the back. And usually I would leave their shoes and socks on just so that they're not having to walk around barefoot on the hospital or imaging center floor. So all their clothing is typically removed unless there's no radio objects. Radiopaque objects such as piercings would have to be removed if they're able to. They put on a hospital gown. Typically, you give them a pillow for their head and clean linens on the table. And ideally, you cover the patient to keep them not only warm, but to provide them some amount of modesty. Okay. When we talk about breathing instructions in a minute, we'll look at that as far as how the patient actually breathes for the exam. We actually make the exposure on exhalation. So the patient takes in a deep breath, blows that breath all out, and holds it out. And then you make your exposure. With regard to your exposure, you want to use the shortest exposure time possible. So you want a high MA, low exposure time. You do have to put a marker on the actual image. Remember, we said that that's legal in order to have the marker on there prior to exposure. And typically we try to use the left marker always, unless it is a right part or the right marker has to be used. The radiologists prefer left marker as often as is able to be used. As far as collimation, ideally you want to collimate to the size of the IR minimally, and then if the patient is smaller than your image receptor, you want to collimate to the area of interest or just beyond. It is possible that it would require more than one image to do on a patient. At times it is possible that not only would you have to do one image lengthwise, you could potentially have to do 2 images crosswise, or even 4 quadrant images is a possibility. As far as shielding, we can shield male patients because the male gonads lie outside the abdominal cavity. Typically, they lie below the pubic symphysis, so therefore they can be lit at all times. Females, I will tell you, even though they're showing you an ovarian shield on this particular patient and her hip, that is not able to be used on an abdomen x-ray. So typically we do not shield females on an abdomen x-ray unless it is absolutely requested by the physician or it absolutely is not going to obscure any pertinent anatomy. Otherwise, we do not use it. As far as our exposure factors, on analog or digital, we're typically between 70 to 80 kVp. Again, you always want the shortest possible exposure time, which means you're going to use a higher MA station. And you have to utilize an adequate amount of mass in order to penetrate the sufficient quantity of photons to penetrate the patient's abdomen. All right. And the only thing, other thing that I'd like to point out on page 115, they do give you some special patient considerations with regard to pediatric patients, geriatric patients, and obese patients. With pediatric patients, the biggest thing that we are concerned with is motion. So you definitely want to make sure you have the least amount of exposure time. With older patients, typically it takes a little bit longer to explain the exam and what we need from them to do. And you want to make sure you give them careful breathing instructions as far as taking a breath, blow that breath all out, and hold it out. And as far as our obese patients, this is where typically you're going to have to do at least 2 images crosswise to each other, or the potential is there where you might have to actually do 4 images and label them as quadrants, meaning you would do a right upper quadrant, right lower quadrant, left upper quadrant, and left lower quadrant. That is a very likely possibility on obese patients. And we will look at that in lecture when we discuss that in just a few minutes. As far as the abdomen, typically an AP supine abdomen is the most commonly ordered exam, but they can also order a PA abdomen, a lateral decubitus abdomen, an AP erect abdomen, or a dorsal decubitus. And those special views are things that we will look at in another lecture. When we look at an AP supine abdomen, this is actually found on page 118. Okay, and when we look at the AP supine abdomen, notice they're telling you that you center to iliac crest and midline. So typically, this will demonstrate any pathology of the abdomen, including a bowel obstruction, any calcifications in the abdomen, ascites, which is kind of like a doughy abdomen. It's excess fluid in the abdomen. And it also could be done as just a scout image prior to contrast media ingestion. You are usually going to be either on a 14 by 17 lengthwise, or you would have to place your image vector crosswise. And you can see right here, this IR is a 14 by 17 lengthwise because this patient is likely to fit on one image receptor. Okay, so this would be 14 by 17 lengthwise. As far as your technical factors, you would use as a baseline 80 kVp at 10 mass. And typically with digital systems, you're probably going to be anywhere between 75 and 85. So a good baseline would be 80 kVp at 10 mass. The patient would lie on their back, ideally in the center of the table. Their arms can be down by their side, legs straight out, nothing bent. Once you have the patient lying on their back like that, you want to center your center ray, which are these crosshairs. This one would go at the level of the iliac crest, and the other one would go midline. So you're at the level of the iliac crest in the middle of the patient. You want to make sure that the shoulders and pelvis are not rotated. The way that you would check for rotation of the pelvis is you would palpate both aces and make sure that they are equidistant from the tabletop. So if you palpate both anterior, superior iliac spines and make sure that they are equal distance from the tabletop. You would have the patient take in a breath, blow that breath all out, and then make the exposure once the exhalation is finished. And then as far as what our image looks like, as far as criteria on there, you need to have the entire abdomen showed, which would include all the way down to the pubic symphysis. You want to see an outline of the liver, the kidneys, the psoas muscles, and you should visualize the arch of the pubic symphysis, which is right at the bottom right here. That's really, really close on that image, but it technically is on there, but that's a little too close for comfort. They could be a little bit lower on that, okay? They are pointing out where the liver is. You can visualize the 12th rib. This is one edge of the psoas muscle. You can see the sacrum, the coccyx, pubic symphysis, obturator foramen, the left femur, iliac crest. So ideally this whole ray would have come at the level of the iliac crest. So right across here would be the one crosshair, and right down the middle for the other crosshair, which these look about equal size, so that centering actually is pretty good with that image. You want to make sure that there's no rotation, no motion in your image, and that your exposure factors are optimal. All right. Now, the other way that you could do this, if your patient did not look like this particular patient right here, and they were not going to fit on one image receptor lengthwise, what you could do, if you look on page 118 at the very bottom, it has underneath respiration, it says notes. And that second paragraph says a broad hyperstenic patient may require two 14 by 17 image receptors placed landscape or crosswise. One is centered low to include pubic symphysis, and then the second one is for the upper abdomen, and they have to have a minimum 1 to 2 inches of overlap. Now that is very common, especially with society the size that it is today. How you would go about doing that, just to describe, so you'd have two 14 by 17s placed crosswise. So your image receptor to the patient would go like this. Okay, so this would be 17 inches this way, and this one would be 14 inches. All right, so you would place it so that the bottom of your image receptor was capturing the pubic symphysis. That's what you would do first, is palpate pubic symphysis and make sure that the bottom of your IR is capturing that. And that would be your first exposure. So you would go back, make sure that the bottom is capturing that. Doesn't matter where the top is. You want to make sure you're in the middle, but the bottom is capturing the pubic symphysis. You go back and set the control panel, tell them to take in a breath, blow it out, hold it out, and make your exposure. When you go back in the room, you basically would want to place 2 fingers in the top of the light field. Okay, so imagine you place your 2 fingers in the top of the light field, and then you want to move the patient down so that your 2 fingers end up in the bottom of your second image receptor. Okay, so this is your second image, and what that means is all of this right between the two, all of this in between is overlap, meaning this was the top of your first image and the bottom of your second image. So all of this is overlap. Now, why do we need overlap? Basically, you're doing that to prove to the radiologist that you've captured the entire abdomen. And if it was quadrants, you would have to do the same kind of thing where you would start with one quadrant, then you'd overlap and include the lower quadrant, then you might go sideways so that you included overlap here, and then you go up and include overlap there. Anytime you're doing multiple, you want to include an overlap so that the radiologist doesn't potentially miss anything when he or she is reading the image and making sure that you captured all of the anatomy and that you're able to prove that. They also reference on page 120 that you could do what's called a PA abdomen, where the patient is prone. You might have to do this if the patient has a reason they're not able to lie on their back for whatever reason. Basically, you would do the same exact thing, except the patient would lie prone. You would center to the iliac crest and midline, same kind of technique, 80 kVp at 10 mass, and make the exposure at the end of exhalation. The only difference when you do a PA is that the final image looks a little different. Like your pelvis, you can tell looks different compared to this image. See how the wings kind of lay out nice and flat, and their PA, the wings don't lay out flat, they kind of come at you. So this was actually done PA. Notice they've included well beyond the superior border of the pubic bone. They have probably a good 3 inches below that. So they could have actually moved up and included a little bit more of the upper abdomen instead of wasting all of that. Same criteria, you have to visualize pubic symphysis. Kidneys and lower liver margin have to be included. No rotation, no motion, and optimal exposure factors. So no different other than the patient is on their stomach versus on their back. Okay, and that takes us up to page 120 of chapter 3. If you have any questions or comments or concerns, I hope you're able to write those down in reference to the slide that we were looking at, or if there's anything that doesn't make sense or you find confusing, please write that down, and I hopefully will clarify that next time we meet live. Thank you so much.